Thank you for our presenter. It's very interesting. For the first paper about the solidonic, it's really interesting. I have a question that patient who did not have a good union, do they have any parameters different from the union patients? For example, the length of the graft, fixation methods, and the size of the tumor.
Thank you for your question. From the all the data review show that first thing that we find is the gap of the graft and the junction of the good bone of the patient. Firstly, and another thing is site of the reconstruction is a bit effect for the unit rate, but the most factor, as I said, and we found the gap between the graft and the junction quite relate to the outcome of the unit rate.
So that is mean the gap of the junction of the graft affect solidonic treatment, right?
I think for the aspect of the union, I think the gap means and affect this, but we didn't find and calculate that whether it relate with the solidonic acid or not, and we're gonna find it in the future.
Okay, you have to keep that one.
Thank you.
Analyze. Thank you. For the last presenter, it's really interesting for your 3D printing. Yeah. Because I use the Mimic 10.11 version also, is to measure the cartilage volume. Yeah. My problem is the precision of the 3D printing and the actual size of the bone. But sometimes when you print it out, it's bigger than the real anatomy of the patient.
No.
No.
I don't think so, because we can actually, the 3D printer cannot achieve cartilage thickness. We cannot assess in this point, but the body part I think is accurate. By the way, it's not accurate because your image acquisition, it depends on your CT scan. When you come back, you have to see the slide thickness. It needs a less than 0.5 millimeters. Normally, CT scan from the outside hospital sent back to me is 5 millimeter thickness. That make you a lot of problem when you need a precise information.
Who is the person who identified the margin that you need to cut it?
Me.
The engineer?
No.
Surgeon?
The surgeon. Surgeon, everything is designed by surgeon. Engineer just help us. What we think, what we design. And me also, I developed myself for 5 cases, but we have an engineering colleague for consultation, but we have developed it by ourselves.
Okay. After you resect the bone out, the tumor out, did you compare the size of the actual tumor site with your 3D printing?
Yeah, we did it on the last year.
Is the same size?
Yeah, anatomical model is similar size, everything with acceptable error range from the slide thickness. The body part is is accurate. Even we use the image fusion method, CT scan and MRI images fusion. We combine bony part and soft tissue part. We can do it together with a registration point that I have shown in the previous slide. We do it and it's accurate with the error range for slide thickness that we can receive in the first time.
Okay, that's why I asked you about the precision percentage of error.
Yeah, it's very important. Thank you.
think I can proceed the question for อาจารย์โทนะฮะ
Thank ขอบคุณครับ
First of all, I very appreciate your work and your team, and I love that idea for and congratulations for Pamongkut team to try to process this one to clinical applications. Just challenge you one question. I love the idea about the jigs for the bone cut. What's your plan? Anyway, if it are going to use in the clinic, the question will come that the jig we have the spade, need a spade for working. Okay.
Yes.
Seem to be the jigs that reduce the operation wound to apply for the minimal invasive in the future. Anyway, the jigs also need a spade to resect more. What is your plan in the future to reduce these obstacle for the real application?
Yeah, I think the custom surgical guide is depends on the anatomy and different location of the tumors. Every time I did it, it takes a lot of time to think because even the similar case, if another surgeon perform the same case, maybe it's can produce a different custom surgical guide because the 3D printing technology is very personalized and everything it depends on imaging depends on that surgeon. So it's difficult to say it depends on the case and on the surgeon because it's very personalized, I think.
Okay,
Yeah.
thank you for your answer. Anyway, I think this question is challenge you to for make it more reproducible in the future.
Yeah.
Congratulations for your team.
Thank you very much.
Question for the first presenter. In your introduction, there's a bisphosphonate is good for the bone remodeling. Okay, but in your outcome, you monitor the healing. Okay, so I want to ask a question that what the role of the bisphosphonate in the healing process of the bone?
Thank you for your question. As we know that the effect of the bisphosphonate like zoledronic acid, but I'm going to explain this from the studies in the past. That let's focus on the paper of the Dr. Belflesh on that published on 2012. That he tried to compare the effect of the zoledronic acid with others chemical substance. And from the biochemical and histochemical study show that zoledronic acid can improve and increase the new bone growth, which is this is the study in the mouse actually. But from every paper that published and have a hypothesis about the effect of the bisphosphonate with the union, show that the bisphosphonate, especially the zoledronic acid, can increase the bone growth.
Okay, so I think next if you have the information about the bone growth and bone healings, I think if you modify a little bit about your introduction to discuss or talking about the bone healing, it might be better than talking about the bone remodeling because it's a different process. Okay, thank you.
Thank you.
Let me add some information. So there's a basic research regarding the local administrative of the zoledronic acid on the allograft years ago, and they found that with the highest concentration of the zoledronic acid, they inhibit osteoclast and osteoclast. So that's not good for this situation. So they have many concentration, and then found that 0.005 that is the concentration that inhibit osteoclast a lot, but minimal inhibit osteoblast. So that's why the idea of the research. So we just think that if it could be possible that if there's less bone resorption, so it could be more union. This is our research. And then initially we have two groups comparison between the group that have zoledronic acid and without zoledronic acid. And then we compare that. And when we already report in the ISOS meeting in in Japan, I think 2 years ago, and that is a significant union time is significant, but with the number is growing and growing. So I'm not quite sure that much. Is it because the union rate, union time of the cyanuric acid group is approximately, I think, 9 months, 9 months or 10 months, and without it's about a year, 1.2 year. So clinically, it's not that much difficult. So I focusing on the complications with or without cyanuric acid. So we focus at the non-union. Do we need to do another surgery for both groups, or we can reduce the surgery for the non-union for the cyanuric acid group? And the result is similar. So we have a non-union for 5 years, and then the patient can run. And then because this is because of the reconstruction. So if we use a long enough stem, so they act like an endoprothesis. So we can have the patient run very good. So that's why I just rethink again that this is necessary to promote faster union. But obviously it's good for faster union for our sense. But in the critical outcome and the non-union and the operation that need for non-union, this is not, it's similar in two groups.
And may I ask Dr. Ukrit, why you use 3 minutes?
Pardon?
3 minutes.
Oh,
Why you use?
I try to brief it. I try to.
You soak your uric acid for 3
Actually,
minutes, right?
from the study show that, like Ajahn Piya said, the concentration and the timing that you soak the bone graft in the hyaluronic acid affect the union rate. High concentration and too much timing for soaking inhibit the bone growth.
And this is depend on the size of the allograft. Is that matter? Big allograft, small allograft?
Actually, from the basic, the area of the surface of the bone should affect this, but because of a little numbers of the patients, so if in the future we have more than the patient more than this study, we're gonna find out.
I think Professor Abulafia have some questions.
I maybe have 2 questions or 1 question, depending on how much time. But for the health-related quality of life in patients who had knee fusion, what was your patient selection? I noticed most patients were females, and in particular, patients who have the toughest time with knee fusions are people who are tall, not like me. So I might do very well with a knee fusion, but I think an NBA basketball player would have a very tough time.
Can I repeat the question? Sorry.
Yeah. Does the patient being very tall or very short make a difference how they do with knee fusion?
Because we don't have the demographic data about the height or size of the patient. But after I interviewed the patient, they think that arthrodesis didn't affect the function and the working after we did the operation.
My experience is the taller you are, the more difficult to live with a knee fusion. Whereas if you're short, like me, knee fusion is...
What's the activity that a tall would do more than the short?
Well, it's not the activity, it's being able to get in and out of a car. It's being able to sit somewhere other than, on the right-hand side, if it's your right knee.
Long leg.
An airplane, it's just having a long leg that doesn't. And in Thailand, I would say riding a motorcycle.
Yes, you're right.
Still have time.
And then, if I have time for another question, you looked at zoledronic acid that was applied topically, and then it was rinsed. And what do you think the concentration of zoledronic acid is in the allograft 30 days after it's been sitting in the body, where there's been blood flow in and out, as opposed to when it's administered systemically and can be actually absorbed onto the bone?
The question is about the concentration that a patient gonna get in the blood flow, right? After, can you repeat the?
How do you know it's still there? How do you know your cellulonic is there?
Normally, from scientific evidence, we cannot find out that this is the cellulonic acid is still in the body of the patient. But our study design, we decided to use the cellulonic acid locally. So we think and we believe that from the local treatment, from just soaking, not intravenous or intermuscular. So the effect and the adverse outcome that we don't want it to occur will not happen, and cellulonic acid will not stay in the body too long.
Yeah, I thought because they have the study about like label with the molecule of the fluorescence, and then it said that cellulonic is still there in the body for like many years until it's still there in the cavation canal, even though the flush and then you have the drain and then blah thing. So.
Okay. Thank you very much for our presenter. I think it's very interesting papers. Please give them a big hand. And I would